coronary bypass, what the intensivist needs to know. First, I would like to extend my welcome to our moderators, two of my esteemed directors and mentor in Canada, Professor Daniel Bainbridge, Professor at Western University, Cardiac Anesthesia and Cardiovascular ICU, and Dr. Paul Cameron, Western Critical Care Program Director, Assistant Professor at Western University. Their leadership and commitment in advanced perioperative and cardiac critical care medicine have been truly inspiring, and it's an honor to have them to guide this session. I'm also delighted to welcome our distinguished speaker, Dr. Ammar Al-Weda and Dr. Mohamed Al-Ghadib. Certainly their perspective today will be a great value to all of us. Before we begin, I would like to briefly introduce our online CBICU fellowship program, which is designed to provide structured and comprehensive learning experience in cardiovascular critical care. It's combined care knowledge and evidence-based lecture delivered by international experts to create a clear, progressive learning pathway. The flexible format allowed to do it in your own pace. The fellowship is divided into 3 modules throughout the year. Module 1, which is a fundamental of CVICU, including physiology, pharmacology, and cardiac diseases. Module 2, perioperative management of cardiac patients. Module 3, which includes mechanical circulatory support. For any further question or details, please refer to the website link provided in the chat. With that, I once again thank our moderators and speakers for joining us today, and thank you all for being here to share with the exchange of knowledge. Let's begin our session, and the floor is yours, Prof. Bainbridge.
Thank you. It's my pleasure to introduce Dr. Mohamed Al-Ghadib, who's a cardiac intensivist, cardiac surgeon, and he works at the King Fahd Medical City in Riyadh, Saudi Arabia. And just as on a personal note, he trained at our institution. We tried to keep him, but in Saudi, they knew how good he was, so they snatched him back. And we both share an interest in astrophotography, although I will admit he's far ahead of me in that field. Mohamed?
Thank you, Dr. Bainbridge, and thank you, Dr. Ahmed and the host for allowing me to present this lecture. Good morning to the attendees, or afternoon or evening, wherever you're logging in from. So this presentation will talk more about, we'll focus a little bit on cardiopulmonary bypass, but I know Dr. Ammar will talk in details more about it. I'm sure much more details than I'm going to talk about. But we'll also discuss the, some of the cardiac surgery, hidden issues that sometimes shows up in the ICU. And there's a central message to this that hopefully we'll share at the end. Are my slides moving okay?
Yes, clear.
Okay. So we'll talk, after we talk about cardiopulmonary bypass, we'll go through the patient's journey through cardiac surgery. We'll talk specifically about some intraoperative interventions for different procedures and how that impacts the patient in the postoperative period, and some a few case-based discussions. There's a good quote that I always like to put in some of my presentation, is that the good physician, from William Osler, the good physician treats the disease, the great physician treats the patient who has the disease. And part of that is, looking at the patient's full journey, and rather than, that snapshot picture that you have the moment he comes into or she comes into the ICU. Going into history of cardiopulmonary bypass is actually very interesting. So the first experimental use of cardiopulmonary bypass was in Minnesota. It wasn't successful, I think, in the early 1950s. But then the first there've been a few attempts at that point for the first few years in the early 1950s, and they were, disastrous. But the first successful case was by John Gibbon in Philadelphia. There are certain requirements, basic requirements. We've come a long way since then, but there are the basic requirements of cardiopulmonary bypass that are still consistent from that time till now. You need some reversible anticoagulation. You need to pump the blood without destruction of cell and Oh, I lost my slides for a little bit. You can still see it, right? Okay, so you need to pump the blood without destruction of cells and a method of oxygenation. So those three kind of pillars of cardiopulmonary bypass they have to be there. I talked a little bit about the early attempts, but just to give you a snapshot of how, disastrous it was at the beginning. So Lily High, who was a famous cardiac surgeon, if you ever read the book King of Hearts, you'll know exactly who he is. He reviewed the literature from 1951, 1955. During those 4 years, 18 patients were reported to have an operation using cardiopulmonary bypass at 6 different centers. Out of the 18, 17 died, only 1 survived. And they used, various ways of oxygenation. There were film oxygenators, bubble oxygenators. There were 5 patients who had monkey lung, and there was 1 patient who had autologous lung as an oxygenator. We've mentioned John Gibbon, his first successful case. So it was an 18-year-old college student who had episodes of right heart failure. The patient had an ASD and was supposed to close the ASD with a pericardial patch. However, during that first successful bypass run, the patient's oxygen saturation rapidly began to drop, and he decided to just suture the defect primarily very quickly, because the oxygenator was a screen oxygenator, was starting to clot because of inadequate heparinization. And this is just to give you an idea of how difficult it was to get this cardiopulmonary bypass off the ground. And as cardiac surgeons, we would not be able to do the vast majority of our procedures without cardiopulmonary bypass. So many lives have been saved by all these early attempts. This is a diagram of what it looks like. It might look complicated, but hopefully I'll try to simplify it as much as we can. So as you know, the way to bypass the heart is to divert blood flow away from the heart into the rest of the body. We drain the blood from the right atrium. It goes into a venous reservoir, and this is the primary difference between cardiopulmonary bypass and ECMO, is that there is a venous reservoir, so the blood is drained from the patient to keep the heart empty and the field bloodless. Then that goes into and also there are some suctions, the cardiotomy suction. If you have a vent, if you have a root suction, they all go through pumps and into a cardiotomy reservoir, eventually goes into the venous reservoir. Then that goes into a pump, the primary pump of the cardiopulmonary bypass, which passes the blood through the oxygenator and then returns the blood back into the arterial limb and into the ascending aorta. So, and this is the basic way of how it works. There's somewhat of a separate pump system, which is the cardioplegia system, which combines cardioplegia solution and sometimes adds the blood from the systemic circulation, depending on the type of cardioplegia you use. And that will allow us to arrest the heart. And that's how we do the biggest portions of our procedure. The venous reservoir, that part of the cardiopulmonary bypass is, as I said, it serves to drain the volume out away from the patient. We can have as much as 1 to 3 liters of blood. There are different types of reservoirs. There's the rigid, hard reservoirs, the open types, or collapsible, closed types. Most centers I've seen will pretty much have the hard, rigid, open type. You can give through the venous reservoir. You can give drugs, vasopressors if you need to, blood products if you need to. Most of the time we just only need gravity, so the venous reservoir is almost down to the floor, but sometimes you can use negative suction to assist in draining the blood from the right atrium or the SVC IVC. The oxygenator, obviously, for now, we had historically many types of oxygenators, but now we have the membrane oxygenator, which imitates the natural lung function, and the gas diffusion occurs and gas exchange occurs through the oxygenator, and the blood is spread through this thin film with multiple layers, and the gas goes in and out through, and the diffusion happens across the membrane. And this is what's similar to, if you have been around ECMO, is what we call a gas sweep. It's a similar function. In addition to this, the way we control the temperature is through a heat exchanger, which I'm sure Dr. Amar will talk more about the mechanisms of those things. Nowadays, we have only two types of pumps, the roller pump and centrifugal pump. Most of the circuit at most centers have roller pumps, except for the primary pump. A lot of the centers now are shifting to more centrifugal pump systems. The differences between those two roller pumps, they are nearly occlusive. They don't care about the afterload, but the downside of those roller pumps, because the way they work is that they squeeze the tubing, the PVC tubing, and that's how they move the blood forward. The disadvantage is that it can cause excess negative pressure. It can cause some air embolism, can cause some debris from the tubing itself, embolization. So that's why now people are moving away from it as the primary pump for cardiopulmonary bypass. Now we're using mostly centrifugal pump. It's not occlusive. It is afterload sensitive, so your flows will drop if the pressure is too high. Just like Centramag LVADs, if you've ever been through them, or the HeartMate 3 LVADs, if you've ever taken care of one, they always, if you have excessive afterload, they will drop their flows. But the advantage of it is it has less contact with the blood. It doesn't it's not as harsh as the roller pumps. So that's why people are moving more towards the centrifugal pump. I've talked about this part of the slide. As you know, the message from this, as you can see, the blood goes through a completely artificial environment. There are potentials for microemboli. There are potentials for air and contact with air, especially with venous reservoirs. So that's why when the patient comes into the ICU, especially if they stay on cardiopulmonary bypass for a long time, they're coagulopathic, they're vasoplegic, because it's not a natural environment, and there's potential for many problems to go wrong, and that's why we heavily depend on our perfusionist colleagues. They're their role in the cardiac surgery OR is absolutely essential, and we would not be able to do what we do without them, and without them being vigilant and focused throughout the operation. An important part that will affect the patient in the ICU, and you might see complications from, is ventricular distension. So if you have a patient that is, for whatever reason, has LV distension throughout the operation, that the surgeon wasn't careful in managing, or there was not appropriate venting of the heart during the procedure, or it was a minimally invasive procedure and you're not able to see the left ventricle, this can have disastrous effect on the myocardial function later on. And this is why there are many methods of venting the heart. The most common method used is the vent inserted through the right superior pulmonary vein. And this is what we do for aortic valve cases, for pump-assisted cases sometimes. The LV vent is inserted here and goes across the mitral valve and sits in the left ventricle. And we use TE by our cardiac anesthesia colleagues to confirm whether it's across the left ventricle, and the presence of TE in the cardiac OR is also essential. And our cardiac anesthesia colleagues will, alert us whether if the heart is distending, if there's a problem. So the whole, to be able to get the patient out of the OR safely requires a whole team that are working in synchrony. There are other ways to vent. You can put a vent directly into the LV apex. You can put a vent into the pulmonary artery, and also the vent through the aortic root, which is almost always present for most procedures. Now, another important part of the cardiopulmonary bypass effect that will affect the patient's outcomes in ICU is the cardioplegia myocardial protection. So for those who are unaware, cardioplegia is what we use as a solution that is given to the heart when the heart is, when the Crux clamp is applied, when there's no blood flowing to the heart, because we're going to, either we're doing a CABG or we're opening to do a mitral valve or an aortic valve. We need a bloodless field, obviously, and we need the heart to be arrested, and it will be ischemic at that point. So we use the solution which arrests the heart using high potassium content and low temperature to decrease the metabolic demand of the heart. If we fail to deliver the right dose of cardioplegia or deliver the right solution of cardioplegia or redosing of cardioplegia at appropriate intervals, because it's not a one and done issue. You have to, depending on the type of cardioplegia, you have to do periodic dosing of redosing of cardioplegia. Then you risk having, biventricular dysfunction or RV dysfunction later on in the ICU. So this is something to keep in mind. So this is a brief about what, the points that matter to the, hopefully that matter to the intensivist. We'll talk a little bit more about the overall patient journey, and I hope I don't take too long. So the journey of the patient, as you know, starts preoperatively, and this is not just, perfectionism. This is really, the real life, of what the problems that happen with the patient in the postoperative period sometimes can start in the preoperative period. For example, somebody who had a late presentation MI, somebody who had a missed late presentation MI or missed STEMI, or somebody who had late intervention for whatever reason. Then those patients, that's late interventions will have sequelae at the end of this patient journey in the ICU, because even if you do your best at fixing it, and if you're not aware of it, then that kind of, you miss a point that's very important in the patient journey. So that's why I think the having a good sit down, reviewing the history of the patient prior to them coming to the ICU, and knowing whether their initial treatments was, in a timely manner, whether done in a timely manner, whether it's effective or not, will save you a lot of hassle when managing this patient in the ICU. And prevention of postoperative complications really start at the preoperative stage. So a little bit about the intraoperative journey of the patient. I'm not going to go too much details into this, but just a few things to keep in mind. We always have neuromonitoring in the cardiac surgery OR, especially if we're doing something like a circulatory arrest case. then that kind of point becomes very relevant, and knowing about it in the cardiac ICU is important. The pump run duration, for example, is very important when you talk about coagulopathy, when you talk about myocardial protection. And I would really repeat on myocardial protection, because this is not something that we often focus on when a patient's handed over to the ICU. And sometimes the patient has, biventricular dysfunction, even though, the valve was done properly, even though the bypasses were working fine, and we're not sure why. But when you look into how the myocardial protection was done, then a lot of the times you'll find that that was where the issue was. And the other question is, if the patient has a long pump run, then always ask, why was it a prolonged pump run? Don't just record that number down and the patient had the long pump run and that's that. But it's important to know why. Was there a problem? Was there a complication? Was there an issue that you need to be aware of? And that will help, plan things later on in the ICU if a complication happened. During the cross clamp time, again, it comes back to myocardial protection. Knowing the type of cardioplegia used, the initial dose and redosing, and was it a single clamp, partial clamp? Did the cardioplegia actually reach the myocardium? And this is a very important question when you have severe coronary artery disease, for example, and you don't have the cardioplegia doesn't, initially at least, does not reach the myocardium effectively, or your redosing of cardioplegia wasn't it was prolonged, or you didn't do it every 20 minutes or so. You were more relaxed during your operation. That will affect how the myocardial function at the end. Some points related to certain procedures, and CABGs, the quality of targets, whether they were adjunct procedures like endarterectomies, were the quality of conduits. These are all very important when, receiving a CABG patient in the ICU, to note those issues. Whether an aortic valve or mitral valve cases, whether there were any conduction abnormalities, any RV dysfunction immediately after a mitral valve operation. And one note I want to mention specifically about mitral valve operation, when we talked about cardioplegia delivery and whether it actually reaches the myocardium, a few cases I've seen during my training and later on during my practices, when we do a mitral valve operation. That's why it's important I think for a cardiac intensivist to spend some time in the OR and see various procedures to understand some of the complications that happen later on. When we do a mitral valve procedure, we, for example, if we go through Syndergaard's groove directly to the left atrium, we always, or even the transeptal, we lift up on the right atrium and the AV groove, and we compress the AV groove where the RCA runs. And when we redose cardioplegia while we're doing the valve, for example, if we're redosing frequently or took us a while, some surgeons sometimes forget to put the heart down, put that retraction down, especially if it's a difficult exposure and they barely got that view that they wanted. But the thing that you forget is that the RCA is being kinked at that moment. So your redosing of cardioplegia doesn't really reach the RCA territory. And then you wonder why the patient has RV failure post-op, even though maybe your cross-clamp time wasn't that long, or the valve repaired itself went fine and haven't done anything to the RV, but you just failed to deliver the cardioplegia that you wanted to deliver. We'll use the rest of the time to go through some of these cases quickly, since I have, I think, 8 minutes. So this first case is a 60-year-old male presented with STEMI, found to have triple vessel disease, taken to the OR for CABG. Post-op, he was handed over to the ICU, and the handover was the following: CABG ×3, LITA to the LAD, SVG to OM, SVG to RCA, and endarterectomy to the RCA. Pump time was 180 minutes, cross-clamp time 120. Due to excessive bleeding, the patient received 4 units of packed cells, 4 FFP, and 6 platelets, and bleeding has settled. After 3 hours of arrival to the ICU, the patient becomes hypotensive, requiring escalating doses of vasopressor support. Knowing what we have talked about so far and looking at this case, what do you think the patient's most likely cause of deterioration? And these are the options. A poll will be pulled up to you for the first question. And please choose what do you think is the most likely cause of this patient's deterioration based on this handover and the information provided. Can we get the first poll up, please, whoever's in charge? Okay. So the first poll is up. If you can choose your options, and then we'll go through the next slide. Okay, Ms. Habiba, can we show the results, please? Okay, so looks like it's split between 3 options. So 26, so the most common chosen option was tamponade, 35%. 26% chose acute RV failure, 30% vasoplegia, and unfortunately only 9% chose graft failure, which, in this kind of scenario, I think graft failure would be the most likely scenario because this patient had, as we said, concomitant procedures also matter. And what happens in the OR, almost most of the complications in the ICU lead back to the OR. So I think the endarterectomy of the RCA is a very important aspect in the history, and that would personally be my first concern in this particular case, especially it's an RCA endarterectomy and the outcomes are not great. This is just a brief slide. There was a meta-analysis that was done in 2017 comparing coronary artery bypass with endarterectomy without endarterectomy. And the outcome that we're talking about here is graft patency, and obviously the patients without endarterectomy did better. Now you can argue that the reason they did better is because their vessels might be better, and that's why they didn't need an endarterectomy. But I think speaking from, there's a lot of mostly retrospective evidence out there that endarterectomy leads to worse outcomes, whether it's because the vessels are bad to begin with or because of the procedure itself. Either way, it doesn't matter. When you have someone with endarterectomy, having graft failure is always on your mind, and that's just one thing I want to mention. We have 4 minutes left, I believe. So the second case is somebody who was a 65-year-old female, post-mitral valve replacement to the tissue valve. Post-op day 0, just arrived in the ICU. She has increasing inotropic support. POCUS shows poor RV function, severe TR, which was traced preoperatively. The LV was hyperdynamic with some inferior wall hypokinesia. ECG shows sinus tachycardia with no clear ST elevation. She's saturating well on FI2 45%. Intraoperative data shows that the bypass time was 120 minutes, cross-clamp time was 95 minutes. Total cardioplegia given was 2.5 liters. Which of the following do you think is the most likely cause of her RV failure? Post-op MI, long cross-clamp time, inadequate myocardial protection, or fluid overload? Ms. Habib, if we can bring up the poll, please. Okay, can we show the results, please? Sorry to be rushing the quizzes, but just for the sake of time. Okay, so this looks a little bit better. So 58% shows inadequate myocardial protection, which is correct. Just going back through the answers, as you can look at the case itself, the cross-cam time wasn't prolonged. There was no signs on the ECG of any myocardial ischemia. And the patient's only on 45% FI2, so it's not fluid overload. This is another just example of, not being able, even though 2.5 liters of quadriplegia for a 95-minute cross-cam time should be more than adequate, but it's not just the volume, it's also whether or not the surgeon actually gave a chance to the quadriplegia to reach the heart. I think I have one more case to go, Dr. Ahmed. Are we able to continue because we have 1 minute, or we can just end here?
You can go for it, please.
Okay. So the third case is a 65-year-old female, post-AVR tissue, Edwards-Magny size 21. Day 7 post-op develops worsening hypoxic respiratory failure despite aggressive diuresis. Readmitted to the ICU and intubated. Chest X-ray shows pulmonary edema. She was optimized, diuresed, extubated, only to be reintubated 12 hours later with the same issue. Echocardiogram shows good biventricular function with an aortic valve, peak and mean gradient of 50 and 35, with moderate severe MR and moderate TR, both of which the MR and TR were mild preoperatively. So what do you think is the most likely cause of this patient's deterioration? Hospital-acquired pneumonia, the mitral valve that wasn't repaired, a coronary ostia issue, or the aortic valve prosthesis? So, Ms. Habiba, can we put the third poll, please? Ms. Habiba, are we able to put the third quiz for this question? There you go. Thank you. Okay, we'll give a 30 seconds or so. Okay, Ms. Habiba, if we can get the results, please. So, most of you chose the mitral valve that wasn't repaired. Then the second most chosen answer is the aortic valve prosthesis. The people who chose aortic valve prosthesis, you are correct. That is the issue in this particular case. However, the next question, I guess you have the answer there. I forgot to put the slide without the answer. So the size of the, is it a manufacturing error, size or type of valve or surgical technique? It's the size of the prosthesis that's the issue. As you can notice, 21 millimeter valve, and as you can see, the mean gradient of 35 immediately post-operative, which is very high, goes with the moderate, at least the moderate aortic stenosis level. So each prosthetic valve comes with, in effect, EOA chart effective orifice area index calculator. So based on the patient's body surface area, you can see whether the patient in green will have no PPM, which is patient prosthesis mismatch, or moderate PPM, or severe PPM. Ideally, you want to always be in the green zone where you have no PPM. So, for example, if this is a very obese patient with a BSA of 2.3 or 2.4, a 21 valve would be small for them, and they are at risk of PPM. So patient prosthesis mismatch really has been shown in a number of studies that it is associated with overall mortality, especially severe PPM, associated with heart failure, frequent hospitalizations, and we try to avoid it as much as we can. Was a controversial issue in the past, but I think most people now are really careful about what size valve they put in. So just to summarize, the central message of this presentation is to always, try to look at the patient as a whole, and look at the patient as remember that they've been through a whole journey from the preoperative period, intraoperatively and postoperatively, and try to dig into as much information as you can about the patient, and that will hopefully guide your patient management in the ICU to become better and better with time. Thank you very much, everyone. I'm sorry if I'm a little bit over my time, and I'll get back to Dr. Bainbridge.
Thank you, and thank you for the excellent presentation. I thought if we have time, we'll just have one question. Someone from the audience was asking about, it's a big question about postoperative cardiac surgical bleeding and protocols or approaches to treating it. So let's give you an example of a fresh post-op AVR who just dumps 200 cc's of blood into their chest tubes within the first hour. Do you want to discuss briefly an approach that you would take, protocol, maybe point of care testing, and maybe a bit on when you would think you should take them back? Do you have any guidelines for people on that?
Yeah, absolutely. So the classical teaching would tell you, 250 cc's per hour for at least 3 hours. That's kind of a baseline, what you tell junior residents starting out, just to give them sort of a guidance. But really what it comes down to is again, going back to what happened in the OR, and that's why it's important to communicate with the surgeon early on. Did you have any expectation of bleeding? Was there any issue? Was the tissue friable? Were there any, issues that can lead to this? And if absolutely there is nothing, then you would check your labs, your coagulation profile. You can do point of care testing such as TEG or ROTEM to better help guide your your management. And in my opinion, if there was no concern intraoperatively and you have, then I would go down that pathway of checking coagulation profile and following, fixing whatever can be fixed. And if everything is fixed and there is absolutely no more room for fixing anything from a medical standpoint, then I think that's the time to actually take the patient back to the OR and make sure there's no surgical bleeding. There is one entity that I'm sure Dr. Bainbridge is very familiar with, since he's also with us in the OR. There are a certain subset of patients, if I remember from the data, maybe about 40% of patients, where you go back to the OR and there is no active bleeding from the surgical sites. However, you do find a large amount of clots, and the theory behind this is when you have bleeding begets bleeding, and when you have clots in the cavity of the mediastinum, that kind of induces the last step of the coagulation cascade with fibrinolysis, and that kind of prevents coagulation in that space. And just by removing the clots, you don't find anything that's actively bleeding, but the patient magically stops bleeding afterwards. So that's one of the subsets of patients that's interesting. I hope that answers your question.
Yeah, that's great. If we have time for a real quick one, because there's one more, and that's the cardioplegia time and adequacy of cardioplegia. And the question is, who determines it, surgeon or anesthetist? Maybe you could give your insights from surgical perspective of when you are worried about adequacy of cardioplegia. Is it always when the heart doesn't function, or do you get a hint that there may be something up during the case because of what would sort of tip you off?
Yeah, it's a good question. So depends on the type of cardioplegia, the dose is different. So if we're talking about cold blood, microplegia, the textbook dosage initially is 20 mLs per kilo, and you're supposed to redose every 20 minutes, 10 mLs per kilo. But we don't always do that. But as Dr. Bainbridge hinted to, there are certain things that happen intraoperatively that warn you that you're not given adequate cardioplegia, or you haven't given adequate cardioplegia in your initial dose, which is electrical activity, the heart starts beating again, and or you open the aorta and the cross clamp is not on all the way, and that's why your cardioplegia wasn't effective. So now you have to redose again, or you have aortic insufficiency and your cardioplegia didn't reach the coronaries and it all dumped into the ventricle. So I'd say depends on the type of cardioplegia, and there are some warning signs in the OR that you haven't given enough cardioplegia or adequate cardioplegia.